Good evening, everyone. Welcome, another Between Us. The time flies in between them. If you've been here before, it's nice to see you all again. If this is your first time, welcome. My name is Katrina Hartman. I'm a development officer with the Royal Alexandra Hospital Foundation. I am part of the Women's Health portfolio, and I work primarily with the Women's Society, and we raise money for the Lois Hole Hospital. I'm really excited about tonight's topic, a little bit taboo, but something that so many of us have struggled with, not that we have to admit it. I want to thank you all for the questions that you sent in. That was a little bit new for us, but it really helped our amazing panelists, prepare this presentation for us. So without any more waiting, I want to bring in Becky McIntyre. She's one of our members of the Women's Society, and she's on the communications committee, and she'll do a few introductions for us.
Awesome. Thank you so much. Welcome, everyone. My name is Becky McIntyre. As Katrina said, my pronouns are she, her, and I'm a proud supporter of the Lois Hole Hospital Women's Society. So glad to be here with you tonight. We've got a lot of people who have joined us. This is great. Whether this is your first lecture with us or you've been joining us regularly at these sessions for years, we're so happy to have you here. Thank you for joining us for tonight's lecture on painful sex. But first, I'm delighted to extend a warm and heartfelt welcome from the esteemed co-chairs of the Women's Society. We have a short video message from them to introduce you to this lecture series and the Women's Society's deep passion for supporting women's healthcare.
Welcome to Between Us. We're so happy you're here. My name is Rhiannon Adams, and my pronouns are she, her.
My name is Vanessa Lancaster, and my pronouns are she, her. We're excited to be here as co-chairs of the Lois Hole Hospital Women's Society. The Lois Hole Hospital Women's Society welcomes community volunteers from all walks of life to join us as we break down barriers and raise awareness and funds for Alberta's only dedicated women's hospital. A hospital that provides such specialized care as high-risk maternal care, minimally invasive surgeries, and treatment of women's cancers.
Since our founding in 2017, the Women's Society has raised close to $1 million in support of the Lois Hole Hospital for Women. Our hospital proudly cares for women in all ages and stages of life, from a landmass covering a third of Canada, and we are proud to support it.
Your presence and support today helps make all of this possible. Thank you. Formerly known as What the Health, we debuted a new brand this year, renaming this engaging speaker series Between Us, Exploring the Mind and Body.
Most often, conversations that start with just between us come from a place of trust. This rebrand represents the essence of trust, where intimate and less openly discussed subjects like personal health matters find a safe space for discussion.
We aspire for this new name to reflect the depth of honesty, intimacy, and expert insight shared during these talks by the speakers who join us. Following the event, we'll be sending out a survey via email seeking your valuable feedback.
Every participant who completes the survey will be entered into a draw for a chance to win a $25 gift card, courtesy of Alberta Blue Cross. A heartfelt appreciation goes out to Alberta Blue Cross for their steadfast support as presenting sponsor, enabling us to host this informative series.
Please join me and Rhiannon in extending a warm welcome to Alberta Blue Cross for the land acknowledgement.
So thank you so much. So I'm Mary Ann Hart. I'm from Alberta Blue Cross, and my pronouns are she, her. And at Alberta Blue Cross, we value the importance of talking about women's health, especially topics such as today's subject. As always, we're really thrilled to be sponsoring this series. And as we get started, I'd like to do a land acknowledgement. So today and every day, we respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory. We recognize that the City of Edmonton and us, the people here, are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada Indigenous peoples, such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We are taking this important moment here today to acknowledge all of the many First Nations, Métis, and Inuit people whose footsteps have marked these lands for centuries. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in the spirit of reconciliation and collaboration. And I'll send it back to you guys.
Thank you, Marianne. Thank you, Blue Cross. We're so happy to have your ongoing support for women's healthcare. And now I am so happy to introduce tonight's conversation just between us about re-inspiring the pleasure in your sex life and learning what you need to know to potentially free yourself from the pain associated with sex. We are going to learn about the myths, mysteries, and misconceptions around what you need to know to better manage your experience with sex. Tonight, we're lucky to have with us 4 physicians practicing at the Lois Hole Hospital for Women chronic pelvic pain program. So welcome to Dr. Annick Poirier, Dr. Lana Myroniuk, Dr. Erin Kelly, and Dr. Sanaee. I'm going to pass the torch over to you ladies now, and you can share your screen, or you can actually come on and introduce yourselves if you want to first, but over to you. So exciting.
Thank you, Becky. So we just wanted to start the conversation by thanking our foundation partners. They've helped organize this event. They supported us through the process and are coordinating tonight. So thank you very much, especially to Katrina. And also we wanted to thank all of you that are out there listening to us. We're hoping to make this presentation or this event as interactive as possible. Thank you so much for sending all the questions that you sent. We try to use them as much as we could in our presentation. We're happy to take some questions as we go, and hopefully we can take several at the end of the presentation. Just to complete what Becky introduced us, the 4 of us work, we're based at the Lois Hole Hospital Chronic Pelvic Pain Program. We work with a group, multidisciplinary team, which means we work, there's physician in that team, but there's also nurses, physiotherapists, kinesiologists or exercise specialists, dietitians, and all of them are essential to the care we provide. We can do what we do without them. And our mission is to support and help patients that live with chronic pain improve their function and live better with pain. So we're going to talk about pain with sex tonight. And this is not only about our body, but we thought we would start there. So the image you see currently is an image of a vulva. And it's pointing to different area. So on the outside, the hair-bearing skin are the labia majora. The inside of the labia majora, you have the labia minora. You have the clitoris, which is the upper portion right here. And the urethra, where you pee from, and the entrance of the vagina. Okay, so imagine you're seeing through someone's pelvis. And so this is from the front. So you have the uterus right at the center. Thank you, Lana. So this is where our babies grow when we're pregnant. You can see the ovaries, which are the 2 golf balls on the side, and you have the fallopian tubes that links the ovaries to the uterus. We have the cervix, which is the door of the uterus. This is where our pap smear are done. And it's also what opens we're in labor and we're having babies. And then the vagina is the canal that's right below the cervix, between the cervix and the vulva. You have to imagine you're cutting me in 2 half this way and kind of looking in the pelvis from the side. So that white patch in the front is the pubic bone, which you can feel at the bottom of your tummy if you feel. You have the bladder that's right behind it. The urethra, which is the little pipe we pee from. We have the vagina, that's right behind. Perfect. And then again, the cervix, which is the door of the uterus, and the uterus. right on top. And then we have the anus and the rectum that's in the back. And I want to really bring your attention to the amount of pain that there is in this picture, because all of that are muscle and they're essential to our pelvic floor function. So in the question that were submitted, we got a couple that were along the line of, is pain with sex normal? What does it mean when you have pain with sex? What is that exactly qualify as painful intercourse or painful sex? So just so we're clear what we're talking about, we're going to talk about definition a little bit. In medicine, we call pain with sex, we call it dyspareunia. And this kind of pain has to be persistent or recurrent. It is pain that can occur before, during, or after sexual intercourse. So it's not just during. It can happen with every sexual encounter, permanently, or for certain at certain time in your life. And the pain can be at the vulva, in the vagina, or in the abdomen. Dr. Sanaee, on to you.
Thank you, Dr. Poirier. You taught us a lot about our physical body, but even though those are our female genital organs, actually the biggest sex organ is our brain. So that is the most important piece of when it comes to sex. We have all this science that actually only came out about 20 years ago, teaching us how sex works in the female body and how arousal happens, what libido is, and how we get motivation for sex. So what we know now is that so much of our sexual experience is in our heads and in our brain and how we perceive that experience. So what happens when we start having pain with sex? Well, we start to not want to have sex. Like, why would you want to do something that causes pain? So over time, we start to say, well, I don't really have interest anymore. I have low libido. But if you really dig down, it might have actually been because of that painful experience that interest starts to dwindle. So what we want to make sure is that if we have pain with sex and we want to rehabilitate that, we have to work on our mind and our body. And the way that we can do that is through mindfulness, for example. So the way that the brain has rewired to interpret pain and expect pain because we've had pain before during sex, that is the problem. That anticipation gears up our muscles, gears up the nerves. We're ready for pain, and guess what? We're going to have pain. So for those of you who are interested, there's this book called Better Sex Through Mindfulness. The first half is more about low libido, and the second half is more about pain. And then there's actually a workbook so that you can work through your own specific experience, because we're all different and the reason that we have pain might be different. 70% of women, people who own vaginas, uterus, clitoris, female genitalia, can only orgasm with clitoral stimulation. So if you've never been able to have an internal orgasm, you're definitely not alone. Actually, you're in the majority. But if we think about it, how much did you learn about the clitoris in sex ed? Or how much do you know about the clitoris? A lot of female sexual medicine and information has been hidden. And actually, there's this book by Rachel Gross called Vagina Obscura, which takes you on this anatomical voyage through our female genital history and almost tells us why we don't know much about it and why we're only learning about it now. And this is actually an art installation of what the clitoris looks like. We only see the tip of the iceberg. This is by Sophia Wallace. If you are interested, she also has a TED Talk on this. So we want to think of sex as a menu. A lot of us were taught growing up, sex means penis and vagina, but it's so much more than that. It can be hand-holding, kissing, sensate focus, sensate touch. It can be oral sex. It can be just with hands. There's so many different ways that we can get pleasure. So if you need to think of other ways that might not bring you pain, because probably there's other ways to have sex that don't cause pain, we suggest the book, The Guide to Getting It On. It gives you lots of ideas. And if you're in a partnered relationship, a great place to start. If you know what hurts, we suggest you stop that and then have boundaries and focus on what doesn't hurt and what brings joy. And over time, that anticipation, that arousal actually makes pain less. So we have this saying, we say arousal is analgesic, which is medical jargon for the more turned on you are, the less there's pain. But until then,
Amy, can I interrupt? a
yes,
second?
please.
Just because you talk about the getting it on book,
Mhm.
because I think we have a great local resource for that as well. The traveling tickle trunk.
Oh, please tell us.
It's just because it's an Edmonton-based business and it's a sex store, but it's really geared towards women. And they have really well-trained staff. It's not intimidating to go there. They also have a great website. But I find that obviously they have product that they're selling, but I think the most interesting thing is that they are very creative about thinking about sex. And so
Excellent.
sometimes you need a bit of guidance how to know how to be creative about sex, and they're really good at it.
So that's the traveling tickle trunk.
Mhm.
Perfect.
Without the French accent.
No, that's perfect. Thank you. This slide is just to say, when our brain, or if we're not fully turned on, it is sometimes hard for our body to be on board. And so we might not have that lubrication made by our body. And so then it perpetuates even more pain because of the dryness and the friction. So it's totally okay to use lubricants. And we definitely encourage that use and for you to test what works for you and try it out.
Let me go back to one slide for a sec. Just because I'm going to be later talking a little bit about genital urinary syndrome of menopause, I want to point out that right here it says not to use oil-based lubricants, but those can be really beneficial after menopause, or if you're in a relationship where you're not dependent on condoms to prevent sexually transmitted infections. One of the simplest personal lubricants you can use is coconut oil.
Perfect. Yeah, this is just for oils can break down latex condoms, but absolutely, and it smells nice. Thank you. So while you're rehabilitating how your mind perceives sex and pain, and you're working on learning more about your own body, and that is our biggest one of our biggest recommendations is, yes, you might have pain with partnered sex, but try it with yourself. Try to see where hurts, where feels good. Again, you were probably not taught about self-stimulation, masturbation when you were growing up, but you can explore where is the pain? Do I bring it on when I'm by myself? If I don't, maybe I have to think back about those pain experiences, and it might be relationship concerns. Or if you can point it out with yourself, if it's very specific, that is a huge guide to us as physicians, because then we can look and see, okay, what is going on right there? So explore and learn. And as that brain starts to perceive sex and pain differently, that arousal goes, and then you'll be feeling much better to try again. Here's a few resources if you want to snap a picture, or you can watch the recording later. Procela is a website, procela.com, which is created by the International Society for Women's Sexual Health. And they have articles on different causes and reasons for for pain with sex, dyspareunia. We have a Canadian-based website that you can check out by the Society of Obstetricians and Gynecologists of Canada, which again is a great resource. And then our own clinic, the Edmonton Urogynecology Clinic, we have a resources section, and I'm going to mention this because a list of local pelvic physiotherapists can be found there. And again, if you want to do some more reading around painful sex, we would recommend this book called When Sex Hurts, and it's written by the founders of that International Society for Women's Sexual Health. So I will pass it on to, oh.
No, that's still you.
That's still me. A little bit of an order change, but this was the slide that reminds us that clitoral anatomy in sex ed, like I said, you only learn, you might learn that, oh, boys get erections. Girls have to prevent pregnancy. That's kind of the messaging. We don't really learn about female pleasure. And if you look in medical textbook, the clitoral anatomy was only started to be included in 2019. So this is just going off on that comment that if you are interested in learning about that there are more and more articles coming out and more books being written. Okay. Now, I'm gonna pass it to Dr. Myroniuk.
Thank you for the segue, Dr. Sanaee. Before I get of the presentation, I'm recovering from laryngitis. If I sound a little bit raspy or difficult to hear, just let me know. I'll be talking about trauma and adverse childhood experiences. This may be upsetting or distressing for some individuals, and if so, please reach out for support. I've listed a few numbers there. The National Crisis Line and Access 24/7 are available literally 24/7, 365. So if anything here or any time ever is upsetting to you, these are some great resources that we have available for free. Okay, so what does trauma have to do with pain? Many of our patients here at the Chronic Pelvic Pain Clinic have experienced some form of trauma, and a significant portion of my work here at the clinic involves linking that trauma and that pain. Trauma is defined as any experience that overwhelms a person's capacity to cope with their life experiences, or circumstances rather. This is important because trauma is a risk factor for many health conditions, including developing chronic pain. It can also change how our brain perceives and processes pain. There are many different types of trauma, and what one person experiences as traumatic may be different from somebody else. So some common forms of trauma that I experience in my practice include single event trauma, meaning that there was one incident that was very difficult, traumatic, upsetting, that leads to the development of trauma. Common things that I see would be witnessing an accident, maybe a car accident or a natural disaster, having birth trauma, having a pregnancy loss, being a victim of an assault. Sadly, we see a lot of patients who are sexual assault survivors here. I often see complex and repetitive trauma, which means it's ongoing. And some common examples that I encounter are living with an abusive partner or working in a toxic workplace that leads to stress chronically in the long term. The third kind of trauma that I often see is called developmental trauma. And this occurs in childhood and interferes with one's developmental trajectory and can affect the attachment that you can form with other individuals as you grow older. I'm going to come back to that a little bit in a couple of slides. But for this infographic that I have here on this slide, this is meant to show the connection between childhood trauma and everyday stresses that occur in adult life and how that can influence a person's experience of pain. The rest of the infographic here is meant to show how pain affects the brain. So this little spiral by number 10 here is meant to show how these changes build like a snowball effect and can then again overwhelm a person's capacity to cope with whatever's happening in their life, which can then affect their pain. This can potentially all start from an event in childhood, and helping patients to connect a childhood adverse event with their pain can be very beneficial when we're trying to treat pelvic pain. So this slide talks about adverse childhood experiences, also called ACEs. And these are negative experiences that happen when we are young, and they lead to toxic stress, which puts the brain in a chronic fight or flight mode. And this can, affect how we cope with stress. It can lead to poor coping mechanisms, and it really is very detrimental to live in a state of stress from a young age. There are just some broad categories of ACEs on the slide here. And again, what's traumatic for one person may differ from another. But I screen all of my patients for ACEs, and many are surprised to learn that something that happened in their childhood was actually considered traumatic. Whatever we grow up with is our normal, and it can be quite eye-opening for patients to be able to connect an element from their childhood with the pelvic pain that they're facing today. How does this tie into pelvic pain and pain with sex specifically? Well, being in chronic fight or flight mode creates physical changes in the body. One of those being your body becomes tense. If you're stressed, if you're on alert and you're looking for a threat, your body is physically tense. That includes our pelvic floor muscles. So the pelvic floor muscles come from your abdomen, go down into the pelvis, around the bottom end, and into the lower back and the sacrum like a sling. That's called your pelvic floor. If your whole body is tense, including the pelvic floor, those muscles become very tight and they can become hypersensitive to pain. The muscles can also fatigue over time, leading to actual weakness of those muscles, or poor coordination when the muscles are trying to work to have a bowel movement or to go pee. So you can have secondary urinary complications and complications with your bowel movements. There are a couple conditions that can develop that we have names for that result from this chronic contraction include myofascial pelvic pain syndrome and vaginismus.
And these are conditions where patients experience pain and or involuntary contractions with a touch to the pelvic floor muscles. So for example, common story that we probably all hear when we're in this clinic is that when a patient who has one of these conditions tries to first insert a tampon when they're menstruating and it hurts and they don't know why. It doesn't hurt my friends, no one else I know it hurts, but it hurts me. And why is that? Or a patient may have gone to have a pap smear or a gynecologic exam for the first time. And they said it was very painful to have the speculum, that device that looks like a duckbill, go into their vagina. Or in the chronic pelvic pain clinic, a very common concern that we see is that when a patient attempts to have sexual intimacy, whether that's a finger in the vagina or penetrated vaginal intercourse, or even with a sex toy, that it is painful. And it can all be linked back to that chronic tension in the muscles, which may be from experiencing trauma. Due to how pervasive trauma is, at the Chronic Pelvic Pain Clinic, we strive to deliver trauma and violence-informed care, or simply trauma-informed care for short. This is a way of providing medical care that assumes everybody has experienced trauma. For example, when I take a history from a patient, I tell them that they are in control of whatever we talk about. And if they don't want to talk about something, they don't have to, and that's completely fine. On the flip side of that, it's also about holding space so that patients can share those experiences if they choose to, so we can validate them and delve into them if they wish. Trauma-informed care is not about treating trauma, and patients don't have to divulge their traumas if they don't wish to. It's about creating a safe space for patients to receive care, in our case related to their pain, and it can be a crucial first step in linking that trauma and that pain, so we can dig into what may be the underlying cause of the pain that we're seeing in the clinic. So if you're interested to learn more, I would suggest these websites. There's ACEs Aware, the Manitoba Trauma Information Education Center, and TAP Me, Toronto Academic Pain Medicine Institute, are all three wonderful websites, open access, free and easy to use, that would have some more information for those who want to learn more. And I'm going to pass it over to Dr. Erin Kelly to talk about genitourinary syndrome of menopause.
Can I just interrupt before I start here? Sorry.
Of course.
And I'm curious to ask you and maybe pick your brain a bit about this, because I definitely feel as a gynecologist, I went through many, many years of training. Granted, it was a few years ago, but I really feel like honestly, I don't remember trauma-informed care being mentioned once when I was training. I think I've started kind of hearing about trauma-informed care, maybe in fellowship training, and in the more recent year, sort of as you continue to learn with on your practice kind of thing.
Mm-hmm.
Do you think family medicine is doing better? Do you think that you guys get better trained at providing trauma-informed care, or do you think it's more commonly taught in those years for residents? Or
not in my generation, unfortunately. I started med school over 10 years ago now, and I had never heard of this concept. Maybe in residency, maybe, but it wasn't a formal topic, which I think is a really missed opportunity for a way that we can help patients. Yeah.
Okay. I guess those things change slowly.
Hopefully.
Big cultural change.
I hope so.
So we had a ton of questions about menopause and the changes that happen in our body with menopause and something that we call vaginal atrophy. So Dr. Kelly has prepared a bit of a more in-depth talk about those things, because it seems to be a huge concern.
Thanks. So yes, we had several questions circling around pain that starts around the time of menopause or afterwards, and what causes it, and is there anything that can be done about it? And you may have heard the term genitourinary syndrome of menopause, or urogenital atrophy, like Dr. Poirier said, or vulvovaginal atrophy. And they all really mean more or less the same thing. Estrogen is probably, as you know, the most or the main female hormone. Before menopause, estrogen allows the skin and the tissue and the muscles around the vagina to be moist and lubricated, and to keep the lining or the skin of the vagina stretchy and strong. Estrogen also helps the body to make a certain protein called glycogen, which helps to protect the vagina and the bladder from infection. And I want you to have a close look at this cartoon drawing here, and you can see what they're calling healthy vaginal mucosa or healthy vaginal skin. That's when estrogen is abundant before menopause, when you're still reproductive cycles and having periods. And you can see how much thinner, and there's quite a significant loss of glycogen there in what they're calling the atrophic vaginal mucosa, or the skin of the vagina that's been affected by genital urinary syndrome of menopause, or what I'll probably refer to as GSM. I think it was just one back. Oh, that's okay. So after menopause, as you're probably aware, women's estrogen levels drop over time. You can have an abrupt onset of hot flushes and night sweats, but you can also have these changes in the vagina and the bladder and the vulva that seem to have a slower progress, that never really resolve on their own. They sort of continue to progress. These changes can include the vagina becoming shorter and the skin of the vagina becoming less elastic or compliant and feeling drier. Often women describe the sensation sandpaper or burning or itching in the vagina. It's the same picture again on the left, so maybe that'll make a little bit more sense now that we know, because it's or we know it's from the estrogen levels dropping. So some of the other changes you can expect going through menopause as estrogen levels drop, the vagina and the vulva may look different. We talked about vaginal dryness, burning, itching, not feeling enough lubrication for intercourse, and often pain with intercourse. Some women will also get frequent bladder infections, and again, this is because of the decrease in estrogen leading to the decrease in glycogen. These symptoms, can cause significant impacts in relationships, emotional distress, and significant worsening of quality of life. Lots of women will start to avoid sex because of the pain and the discomfort. Unfortunately, having sex less often or not at all, which often can make the pain worse. So what are the options for treatment for GSM? Well, there's really a huge array of options. To start, the Canadian Menopause Society suggests simple measures that you can take at home. This is kind of healthy, or what we consider healthy vulvar and vaginal care. So you want to avoid soaps and detergents. Simple warm water is enough for cleansing. And it's always a good idea to use a lubricant for sex, like Dr. Sanaee was saying. This could be water-based, silicone-based, or as I mentioned before, if condoms are not a concern or not used in your relationship, you can use oil-based lubricants. When we're talking about vaginal moisturizers, sorry, can you go back one? Sorry, that's okay. These are products that you can use every day or every other day to help with that sensation of sandpaper or dryness. There's several products that are available over the counter. I just have a few pictures of 3 of them here. Replens is a really well-known brand that makes a daily vaginal moisturizer. Gynatrof is a gel moisturizer, and Repagyne is a suppository. But sometimes the simplest vaginal moisturizer you can use every day, again, is my favorite product, coconut oil.
Do you mean like the kind you buy at the grocery store?
Sure do.
Like the white stuff?
Yeah.
It's perfect. It's solid when you put it in your hand and then it becomes liquid.
Beautiful.
Olive oil would just be so messy.
It tastes like,
All
smell
over
like
the
an
place.
Italian dinner. No.
No, coconut oil. Smells good and it works. All right, what's the next step for the treatment of GSM? So you've probably heard of hormone replacement after menopause, or HRT, and that is something completely separate for another talk. Here we're talking about local topical estrogens. So these are products that come in a suppository form that's inserted into the vagina with an applicator. It could be a cream that goes in an applicator and is inserted into the vagina, or your doctor may talk to you about, sorry, a healthcare provider may talk to you about putting it on the vulva or the urethra. Or it can even be a silastic ring that stays in the vagina for 3 months at a time. These products, some of the common ones, I've got little pictures here. Vagifem is a commonly used suppository that used 2 to 3 nights a week. And Bexy is a suppository that comes without an applicator that again used 2 to 3 nights a week. Premarin cream, estrogyn cream, both estrogen containing products, again, 2 to 3 times a week. And the E-string you put in for 3 months at a time, forget about it, and then change it out. There are some newer products that are really promising for the management of GSM, and one of them is a product called Prasterone or Intrarosa. It is similar to estrogen, but it is an estrogen precursor and in fact a weak testosterone. It works by getting converted to estrogen once it is taken up by the skin cells or the mucosal cells of the vagina. And it's actually been studied to increase libido in postmenopausal women, but so far the efficacy of that is uncertain. The other one I have here is called Ospina. That's technically a selective estrogen receptor modifier type medication, which is really not important to remember, but can also have positive effects on the skin of the vagina where it has estrogen receptors without having any clinical detectable effects on other places in the body where there are estrogen receptors, like the breast or the endometrium, which is the lining of the uterus. And the benefit of Ospina is it's an oral tablet you can take. We get asked this, I think, every day, maybe multiple times a day, but is estrogen safe? There's been so much controversy, unfortunately, about hormone replacement therapy, but this is a significantly different product. Like I said before, it's topical, it does not get absorbed into the bloodstream when they've studied it, and it really works very locally just on the vaginal skin. Some questions that came to us were about long-term use. And I can just tell you that long-term research studies have not shown any increased risk of breast cancer, endometrial cancer, heart disease, stroke, or venous thromboembolism, which is a big word that means blood clots, with any of these topical estrogen supplements or the Prasterone or the Ospina. And unlike hormone replacement therapy that you take by mouth, the dose is low enough and the absorption is so insignificant that you do not require to take progesterone to balance out the estrogen.
Erin, there's a good question in the Q&A section, and I think you alluded to it, so maybe I can ask you and then you can complete what you were talking about before. So the person says, can increased sexual activity actually help and or slow the atrophy of the vagina? And I think you said before that the answer is yes. Do you want to talk a bit more about that? I think it's like increase of the blood flow and elasticity that sex helps with.
That's all I know of. If anyone else wants to jump in, but increasing blood flow, maintaining stimulation of the tissues, maintaining lubrication, just promotes
Healthy vaginas.
Healthy vagina,
So good.
easier sex, more comfortable sex over time.
Very good. Thank
Good
you.
question. The other question that we get all the time is about if you have a personal history of breast cancer, or if you've had a family member with breast cancer, is it safe? Often we're told, lots of women are told it's not safe to use vaginal estrogen.
And blood clots too, right?
Yes, sorry, yeah.
Only because it was just a question that popped up, so I figured you could answer it all at once.
But the reality is, not in women who have blood clots, but with women who have breast cancer, personally, symptoms of GSM are very prevalent. So it can be a huge issue in breast cancer survivors because a lot of the treatments or the chemotherapies are actually anti-estrogen. Mm-hmm. And because breast cancer is often diagnosed relative to the onset of menopause, and treatment for breast cancer can bring on menopause sooner. So the use of low-dose vaginal estrogen therapy has not been found to be associated with increased risk of breast cancer, occurrence or recurrence, and like Dr. Sanaee pointed out, blood clots. Did anyone else want to add anything about GSM?
I have a favorite fact
Please.
that I just learned that I want to share.
I knew you had something.
Did you know that a full year supply of vaginal estrogen, exactly what Dr. Kelly just explained, a full year supply is the same amount of estrogen as 1/4 of one birth control pill. The amount of estrogen is so low. So for the person who said, I was told I've had a blood clot, I can never have estrogen. Yes, you should not have estrogen that goes through your whole system, but vaginal estrogen, if you want to be super conservative, maybe within the first year of your blood clot, if you want to be really conservative, but honestly, it's so low.
Well, especially now that we have options that are even lower in estrogen, right?
Yes.
Because now we have the 4
Yeah, that's nothing. 4 micrograms.
Imvexi.
Yeah.
And you can always start slower, right? Like you
Yeah.
don't have to go like, if the recommendation is to use it every night, you don't have to
No.
do that up front if you are nervous about it. You can start once a week and see what happens. Some women, that's enough to get, improved quality of life. So that's all you
Totally.
need right now.
Yeah.
Just because you're on the question topic, I thought I would jump in and ask the question about migraine. And I think you just answered it with your description of how incredibly low the amount of estrogen that is used is. But there is a question here that someone was told that vaginal estrogen may cause migraines, and so to discontinue its use. So
This is important if it's okay.
Of course.
In Canada, we have something called class labeling, which means that the pharmaceutical packaging has to include all warnings because it's the same type of medication. So whether you're taking the estrogen as a pill at a huge dose, or you're putting it on your skin at a huge dose, or you're just putting a little minuscule dose in your vagina, the product monograph has to say all the risks. So yes, it's going to say that it's going to increase migraine, it's going to cause breast cancer, it's going to cause blood clots, all these scary things, because it's still in the same class. So this is why your pharmacist might be very scared, like, why would you want to do this? But you could just be confident that it's for that reason. It's just class labeling.
that's such a great point that I think is important for everybody to understand, that it's like a blanket application of the warning, not necessarily specific to that individual ingredient or item. Thank you.
What a hot topic you have on the slides here, Dr. Kelly.
I think so.
Yeah, that's very brave.
So the final thing I was going to talk about was vaginal laser, because as I would assume you're well aware with the type of questions you're asking, there are lots of women who have contraindications to estrogen in general, or are told they shouldn't be using vaginal estrogen, or are breast cancer survivors and perhaps on certain chemotherapies and can't use vaginal estrogen. And so this alternative treatment for GSM kind of emerged in the mid 2010s, where an energy device or laser became a potential treatment for GSM. So the hypothesis behind this fancy laser is that the beams of light would create a controlled thermal or burn injury to the vaginal skin, thereby increasing blood flow and stimulating collagen remodeling and regeneration. So there were a few initial research studies on this laser that were based on small groups of participants that were funded by the laser companies and were biased towards positive results. They weren't tested against a sham, and so they looked really, really positive. Because lasers are already used for other skin aesthetic procedures, they've already been approved in Canada for another reason. And so any clinic that provides this type of treatment can easily move to vaginal laser without any concern. The problem was the studies were not really, research studies were not really robust and still aren't robust enough to show whether it's truly helping and beneficial for GSM or if it's actually causing harm. So there were multiple guidelines that came out from the Canadian Menopause Society, the Society of Obstetricians and Gynecologists of Canada, as well as The several societies worldwide and in the US just cautioning against vaginal laser and reserving its use for research studies only until better results were available. And actually, since those guidelines came out, there has been 2 or 3 well-designed research studies where participants in the study got laser, or they actually got a sham procedure, so not a real procedure, the closest we can get to a placebo. And there was actually no benefit over the long term with these treatments. The reality is there's very low risk of serious life-threatening type adverse events, but very likely the laser is causing a burn injury and not really causing much more than that. And I suppose the serious event associated with it is because these are not technically medical treatments, they're very expensive. So you could be paying close to $2,000 for a vaginal laser treatment that is unlikely to improve your symptoms.
Actually, somebody mentioned that in the comments. They said it was actually recommended by their physician, and it was $2,900 initially,
Gosh.
and then $1,000 a year thereafter. So I hope that what Dr. Kelly just said answers your question.
Take that money and go see a pelvic floor physiotherapist.
Yes, spend that money on a pelvic physiotherapist any day.
Okay, so you were all done, right, Erin?
Yeah.
So, Brianna, can I just ask, is there any burning question from your end of the screen before I move on with the last part of her presentation?
I think the question that keeps coming in is just how to access the clinic where you all practice.
Oh, they love us.
You need a referral from your primary care provider. So your family doctor, if you don't have one, you can go to a walk-in clinic, or if you have a nurse practitioner. If your provider doesn't know how to refer to us, we are on the Alberta Referral Directory. Unfortunately, women health is grossly unfunded, and so access to care, generally speaking, is poor, despite our best effort to improve it. So there is a bit of a waiting time to come and see us. Yeah, I don't know if that's clear enough for people to, if anybody wants to add anything.
Yep. Seek a referral and from your primary care provider. And if you don't have a primary care provider, hit up a walk-in and ask for a referral specifically.
And
That's
often
great.
we might give recommendations back to your family doctor because of our long wait times. We might say, oh, have you tried this? Have you done this? Based on your story, we would recommend this, just so that you're not waiting for a long time with no guidance. So you can still work with your family doctor.
Fantastic.
Okay. If that's it, then I'll carry on with the next portion of her presentation. So I put this picture up because I wanted people to be impacted by the amount of muscle that there is in the pelvis. So Lana, can I use your finger again?
Yes.
Just if you can just point out the pink area. Those are all the pelvic floor muscles. There's several layers and different groups of muscle in the pelvis. And if you can think about it, this is like this is the floor of your body pretty much. Lana, if you can point the spine so they know where the back is. Thank you. And then the pubic bone in the front. Thank you. So when we in pain, muscles are usually important. Anywhere from 85 to 95% of patients will have some pain. At least some of their pain will be from the muscle. Sometimes it's muscle pain alone, and often it's muscle pain associated with something else. And in the pelvis is the center of your body. It's connected to your hip, to your tummy, to your back, to your legs. And the pelvic floor muscle are part of your core muscle. So it's on the same kinetic chain as your abdominal muscle, your hip muscle, your lower back muscle. And there's so many interactions between all of those muscle groups, and so many ways that this mechanic can go wrong. If you put the next slide, I think, Lana, they'll really see what I'm talking about. I mean, in this slide, you see the main muscle groups, but you know, there's also muscle at the vulva, inside in the vagina. So there's muscle all over. I'm just going to talk 2 more minutes about the muscle. There's often, as Lana actually talked about quite a bit already, you were talking about it more in relation to trauma. But just like people have pain in their neck or their back because they have tense muscle, you can have tense muscle in the vagina. We don't have the same awareness of those muscles because it's not a muscle that you need per se. But there's definitely a lot of tenderness in those muscles for a lot of women. It can be because of trauma, as you mentioned before, or it could be associated with an organic disease. So if you think about it, like if you were to cut your arm, all the muscle in your arm would go stiff to protect you. So you don't move your arm for, you know, the cut to heal. But once the cut is healed, you would start moving your arm and your muscle would recover and loosen up and you know, start being more functional. You know, for women that have had, for example, years of painful periods, it's like having a cut every month. And then the muscle never has time to really loosen up. So you end up with those very tense muscle. And if you think about it, if your muscle is tense, it's like walking, like it's like if you were, hold on. This way maybe? Okay. Yeah. It's like if you're walking with your bicep and contracted all the time. Like I think it's pretty obvious that if you walk around like this all day long, at the end of the day, you're going to be sore, you're going to be tired, and your arm is absolutely not functional, right? So this is exactly what happened with those core muscle, but we're often just not aware that this is happening. I mean, again, when I train, we didn't even talk about those muscles. We didn't ever examine those muscles. So there's something we, you know, I've discovered the importance of this so much later in my training and career.
And can I just bump in for a second, Dr. Poirier, that you mentioned that even as an OBGYN, you weren't trained to examine those muscles. I'm a family physician, so even less formal training in this part of the body. And I would say most family doctors, if you were to present with pain, and maybe it's from one of these conditions, they may not know how to examine those muscles. I learned how to do that from pelvic floor physiotherapists. This is where I got my training for that. So it's a very, I think, specialized physical exam maneuver that many physicians who don't practice in this area may not even know how to fully assess. Sorry to interrupt.
No, that's perfect. So I picked some questions that we got that I thought were related to muscle function. And so the first one that was interesting, if you go to the next slide, Lana. A person in the community asked, how effective is pelvic floor physical therapy in reducing painful sex? So if we go to the next step, I had to put a unicorn in this presentation because I have a 6-year-old daughter and she would be very happy with me right now. She loves rainbow and unicorn, but this is how I think of physiotherapists. They are quite magical. So they are excellent, you know, they're specialists of the muscle. Their role goes beyond just Kegel exercise. In fact, when you have pain, it's not at all about Kegel exercise. It's about learning to relax your pelvic floor muscle, about lengthening and stretching. And it's like any other healthcare providers, they all have their area of expertise. You may have a wonderful therapeutic relationship with them, or you may find that you're not connecting well with this person. So like any other healthcare provider, you may have to explore which therapist is the best for you. You know, you may have to explore what their area of expertise is. But I find that for the vast majority of my patients, physical therapy is essential to recovery and healing. We got this question from another member of the community. After giving birth, is pain during sex common? It is so common, so common. I mean, I think, you know, in the immediate postpartum period, even more so, the majority of women will have some degree of pain. And then for some women, it will translate in, you know, sort of medium or long-term pain. either pain with sex, but it can be also, more chronic pain as well. And there's multiple reasons for that. You can go to the next slide, Lana. I think, what's the right word? The postpartum period is definitely an intense period of your life. There's different hormonal changes. We often have a scar, either a tummy scar or, a perineal scar or a vaginal scar. The muscle have often reacted to this intense experience, to the emotional aspect of the experience, but also to the physical aspect of the experience. Like, think about it. Birth is a massive challenge for the body. There's muscle trauma, there's nerve damage, there's ligament damage, and somehow we manage to recover from all that and do pretty good. So it's not surprising that sometimes there's some hiccup in our recovery. And there's also often multiple reasons to have changes in our sexual response. So as Dr. Sanaee mentioned before, it's a very complex reaction, but we're tired, we're emotional, there's lots of adjustment in the couple, there might be adjustment with the family. So there's a ton of reason to not be in the best place. And so my main message to you is that if you're struggling with pain with intercourse after having had a baby, get help early. So we do in the program have a special clinic for moms that have had traumatic birth. It's called the perineal clinic. The access to that clinic is pretty open, I would say. We've purposely designed it so that patients could access it early and easily. Anybody can refer you, a resident, a nurse on the postpartum floor, your family doctor, your midwife, any healthcare provider in your life. Especially if you experience pain with intercourse, poor healing, urinary leakage, sensation of vaginal bulge, you're a good candidate for the perineal clinic. And we know that if you get help early, you are more likely to do well and heal well. If you go one more, Lana, we're going to have the next question. Nobody has anything to add this far? That's good.
So good.
Okay. Another great question we got. What could pain in the deep in the pelvic during sex indicate? So in medicine, we often like to put things in boxes. So often we'll talk about superficial dyspareunia and we'll talk about deep dyspareunia. So this pain, usually patient will describe it that they have pain with deep penetration, like high up in the vagina or inside their tummy. This is like, we're not trying to do, I can't give you a diagnosis here. I don't know you, I don't know your full history, I've never examined you, but I can certainly brainstorm some ideas. So some of the things I was thinking of, and my colleagues can add to this, was it could be endometriosis. So this is a disease where the lining of the inside of the uterus kind of grow outside of the uterus, and that creates a state of inflammation. It's usually much worse with menstruation and with intercourse. It can also be pain related to pelvic floor muscle. It could be a pelvic mass. I thought that maybe an ovarian mass or something related to GI maybe, or to the bowel. And the main message is if you have really deep pain, you should really see a healthcare provider. Another great question. Brianna, is everything okay on your side?
There's some really great questions. I'm getting excited.
Oh, the next one. Are we inducing more question or are people just being quiet?
You're doing a great job. There are questions coming in, but you can keep going with
Carry on for now?
Yeah, absolutely.
Okay. So this question, can previous medical treatment or surgery cause painful sex? Yes, absolutely. This is a tough one for a lot of healthcare provider. And unfortunately, I think some people are so uncomfortable when something goes wrong that they might be a little bit in denial. But definitely, and there's multiple reasons why procedure or surgery can cause pain. So again, if we go back to my idea of, if you cut your forearm your muscle might be reacting to that, and you may have stiff muscle or tense muscle or tender muscle. So there may be a component of muscle pain to your post-surgical pain. An acute episode of pain of whatever source, but including surgery, can induce like a hypersensitization of your brain. So your brain, it can cause, a brain dysfunction and or nerve dysfunction as well. So your brain and your nerves may start registering all the stimuli as being painful stimuli. You may have issue with scar. Maybe your scar is causing some pain. So there's many reasons why you can have pain after surgery. Hopefully, you have the ability to go back to your healthcare providers to discuss this in more depth. Oh yes, I like this question. Because we also take care of prolapse. So this was kind of nice that both prolapse and pain were meeting in this question. So will erectile cystocele cause painful sex? What happens to the prolapse during sex? Are they pushed out of the way? So classically in medical books, they say that prolapse are not painful. I think it's not entirely true. I think a lot of women have a lot of discomfort, a lot of bother, and it's a little bit hard to trace the line between, where does the discomfort stop and the pain start. It is completely safe to have sex with prolapse. The prolapse just kind of move out of the way, exactly as this person described it. If anything, again, for any pelvic floor disorder, sex is good. It's a healthy way. It improves blood flow. It increases elasticity. So it's a good thing. It's a healthy habit. However, so the only women that have pelvic pain often have the same risk factor than women that have prolapse. So we often find chronic pelvic pain and prolapse together, and it's hard to distinguish because if they're both there, we don't have a test per se. It's only your clinical examination. And so, prolapse, women get prolapse because they had babies, they again had damage done to their muscle, nerve, during labor and pregnancy. And it's the same thing with chronic pelvic pain. So definitely we often find those two conditions in the same group of women, if that makes sense. Did I explain that properly? Yeah. Good.
And to loop back into what we talked about earlier with lubricant, do you think lubricant can help in this population?
It can help with pretty much everybody, right? For
Great
everybody,
idea.
but I agree,
Yeah.
you're right.
You can get
Absolutely.
way more friction, right, on the tissue.
Yeah,
There's
absolutely.
prolapse. So
And we often use a vaginal moisturizer and vaginal estrogen for women that have prolapse, because if your tissue are more healthy, if they're more lubricate, often you're less symptomatic as well. So yes, it's a great idea. Thank you for flagging.
all connected.
Yes, definitely. Okay, I think maybe let's move on to the next question. Okay, I'm hoping that I'm not gonna disappoint the person that wrote this question. I wanted to make a point with the question, so I apologize if I don't answer what you were looking for. The question said, I had a total hysterectomy last October. Since then, I have continued to have a heavy feeling and intercourse is painful. I am extremely sad and distressed by this. What is wrong? So first of all, I'm so sorry you're having this difficult experience. You're not alone. And I just wanted to talk about the emotion because I really felt for you when I read the question. Women that have pain with sex can experience a very broad range of emotion. And unfortunately, those emotions are often negative. A lot of women talk to us in clinic about being afraid of being rejected by their partner. They feel guilty. They feel like they're not fulfilling their woman's duties. They're feeling they're inadequate. They have low self-esteem. And there's quite a bit of distress and sadness and frustration around pain with sex. We do recommend to all of our patients that comes in the chronic pelvic pain program to seek mental health support. And a lot of patients look at me and tell me, do you think this is all in my head? I mean, we know that part of pain is in the pain system. The pain system is in the brain. So part of the pain is actually in your head. But for all of us, we never mean that our patient are crazy, but it is a very difficult journey to be on. And so mental health support is essential to recover and heal. And I think that's all we had prepared, Brianna. So now it's the fun can start. You can quiz us and see what happens.
Fantastic. Thank you so much. And you've all been doing a wonderful job answering questions as they come in to the chat as well. So thank you for that. There's a couple questions here about lichen sclerosis. And so I think that's a great topic to maybe dig into first. One of the questions specifically asks about the relationship, or is there a relationship between lichen sclerosis and or bladder problems or other issues in that area? So I'll let you dig in.
We're just having an overhead announcement. One moment, please. There we go. I'm so glad that this was asked. So just like Dr. Poirier explained, like in medicine, we like to put things in categories and boxes. So our first question is usually, oh, you have pain with sex. Is it superficial, like just at the entrance, or is it deeper inside? And then we kind of do our shuffling. Oh, it's at the entrance. Okay. What are the things that happen at the entrance? One of those things is a condition called lichen sclerosis. Another one is called provoked vestibulodynia. Those are the probably two most common causes, I would say, for superficial or entrance level pain with sex. Lichen sclerosis it used to be called a rare disease, but now we know it's actually quite a common condition. And it is probably an autoimmune condition. But when I see patients with lichen sclerosis, I just show them my eczema and say, you know, some people get this kind of rash on their body. Lichen sclerosis is a different type of dermatologic or skin condition, but it can definitely cause a lot of problems, and it is a chronic condition, so it doesn't just go away on its own. It does ebb and flow, like there will be times of flare and times where it's quiet, and of course we want to increase the times that it's quiet so that you can enjoy more comfort and hopefully also more comfortable intercourse. So lichen sclerosis is an inflammatory condition. So what happens is that the skins, because it's inflamed, it can become very itchy. So an itchy vulva always makes us think, could it be lichen sclerosis? And aside from that, because of that, the mainstay of treatment is an anti-inflammatory, a strong anti-inflammatory, a steroid. So if you have lichen sclerosis, you've likely been prescribed that. There's actually a lot of ways you can treat lichen sclerosis. There's dietary changes, sometimes hormones are related. So I have two recommendations for who to follow on Instagram. One is Dr. Jill Krapf. So that's Jill, JILL, KRAPF, MD. Is an excellent resource. She has a little infographics about lichen sclerosis and the different treatments you can try. And then the other person I would say to follow is the Lost Labia Chronicles. And that is a patient who shares her experience with lichen sclerosis, because over time, with the itching, with the inflammation, the labia, like the inner lips, can actually start to shrink and different parts of the vulva can fuse, and you lose what we call the architecture of the vulva. So that is my little spiel on lichen sclerosis. I hope that answered some of your questions.
Can I add a great one to follow on Instagram if you're into social media? Hello Vulva.
Oh, yeah.
Not just lichen sclerosis, but covers a lot of vulvar pain conditions. It does cover lichen sclerosis, and I love just seeing their little updates every day, because they really do a great job of educating with a little bit of humor at the same time. So Hello Vulva, easy to find.
Yes, hello.vulva. It's out of BC, right?
Yeah,
Mhm.
yeah, and Canadian.
Canadian, very good.
I think one of the really important message with lichen sclerosis is to not stop treating. I think there's really a fear of steroids out there and cortisone. I mean, it's most of us, the one recommended steroids for lichen is called clobetasol. That's the main product that we use to treat lichen sclerosis. And it's true that they are warning regarding the use of steroids and clobetasol. But it is the appropriate treatment for this specific condition. And when you use it for this specific condition, it is completely safe. And it is in fact recommended to use it, I mean, for patients that their symptoms are completely controlled, to continue using it twice a week for always. And for the patient that will do that and be diligent and continue with their treatment, we know that they do much, much better. And the risk of like sinister event, like a cancer related to the lichen, is actually zero for the patients that diligently continue with their clobetasol twice a week for always. So it's really important.
And as a little patient advocacy side note, not everything that itches is a yeast infection. So I've seen patients with lichen sclerosis where it's actually quite severe and they've just sort of gone to a healthcare provider, been told it must be yeast infection, try this, try that, and they've gone months or years with no proper treatment. So if you have not been examined and nobody has looked at your vulvar and perineal tissue, don't be afraid to ask for that, because it can only be diagnosed visually, or if your provider is not sure, they can refer you if they see something that doesn't look quite normal. And know your own vulva. Get out a mirror, get out a hand mirror and look and know what your skin looks like. Thank you. Well, I think a lot of people are afraid to look there. They don't know what they're looking at, right? But if you notice, hey, this skin looks different, that's actually very helpful for a healthcare provider to know that maybe there's something dermatologic causing the itch or the pain, whatever.
Fantastic. I love it. Get to know your vulva and what it looks like, right? And I think it's I was just looking up, there's that project, The Great Wall of Vulva. It doesn't really show like skin per se, but does show the variety of shapes and types of vulvas. And I, being that you all are around vulvas lots, I'm sure you've seen lots of different types, but most people have only seen theirs, right? And they're not so familiar with what the variety can be. So thank you so much for all of that and for the information about lichen sclerosis. And I think, understanding that it is something that we manage long term. It's not something that we necessarily like treat once and it's gone sort of situation. So chronic condition that we need to manage ongoing to reduce the risks of other issues. Yes.
Add on to that, because I think one of the questions about lichen sclerosis was about other symptoms like bladder and such. And I think what's important to know is just because you've been diagnosed with lichen sclerosis doesn't mean you also don't have GSM, or low hormone in the vagina, which is more what can cause bladder issues and burning and infection. So there was a question about like exactly what you just said, where these are chronic conditions, so you need to treat them ongoing. But the thing that I think it was a pelvic physiotherapist who said it once, was like, do you ever ask your dentist when to stop your toothpaste? Like once you start these treatments, including the vaginal estrogen, this is a lifelong commitment, because once you stop, it'll come back. And because we know they're not long-term harmful, just think about it as toothpaste.
I love it.
So good. A few questions have come up about the Urospot specifically. And I know, Dr. Sanaee, we talked about this in the previous pelvic pain lecture that we had, but would anybody like to dig into that?
Do you want me to
Go
start?
ahead, sure.
I think, the way we're answering, I think, is a good reflection of the discomfort we have to sit with. I think it's not not something that's well accepted in the medical community. Is that a good way to describe it?
Well, I think the way I answered it previously, I didn't make a good distinction between the Urospot is a clinic and they offer different things. So they do offer things that I think like pelvic physiotherapy, which we very much support. But they have some machinery and some devices that are not fully.
You're right. I assume it was the chair. I assume it was the chair what we're talking about. Maybe that's a
Me
poor
too.
assumption on my part.
No, but I think I made that same assumption when I answered this back in January. So I think there's so many questions about this chair that our Canadian Society for Pelvic Medicine is working on a position statement, because there are some research studies, but unfortunately, at the end of the day, the research is not showing long-term, long-lasting effects. But you might get benefit for, say, a month, with like incontinence, but is that worth the thousands of dollars? That's where it's difficult. And then if you have someone who has those tight muscles,
That's it. That's the.
And you go sit on that
big
chair?
warning, big warning.
we've seen patients come in with pain, like a pain flare, because now you've really tightened and stimulated muscles that should not have been on that chair. So it's hard to say.
Yeah, and I think I presented to the patient like this, it's a bit of a gamble. You're gonna put lots of money in it, you're not sure if you're gonna get any effect. Pain is a red flag, it shouldn't be painful at all. And I think we have treatments that are well-known, that are not risky at all. So might as well put your money in the one that we know for sure are helpful, like physiotherapy. Yeah, that's my 2 cents.
Awesome, thank you. And a few questions have come in. One that I'm not sure if I got answered, but I think it's a neat one to maybe discuss for the YouTube recording. Was somebody was offering that they're 62 and they've been sexually inactive for 15 years, and we're getting married very soon, and so feeling like, what should they do next? Is a vaginal moisturizer kind of a good way to start? And of course, I know we can't give personal medical advice, but just in this context, I think there could be many women who are sexually inactive or like not experiencing penetration for a period of time, and then engaging in a new relationship and trying to figure out how can I reduce pain and things like that, especially as we advance in our lifespan. So I thought I would offer that one up.
Say congratulations first.
Yes,
That's
congratulations.
That's amazing. Falling in love in your 60s. It's like a movie. Definitely.
I just give it vaginal estrogen like candy, so I would say just skip to the thing that's actually going to help. But the more conservative answer is yes, start with moisturizer. Would you agree?
Yeah, and I'm gonna plug again for the coconut oil, because you can use that for everything. And of course, the vaginal moisturizers that have hyaluronic acid and all these other things in them are really safe. There's very little known side effect or downside. The worst case scenarios, they don't really do very much, but they're very safe to use. And I agree. I think the prescription we give out the most is vaginal estrogen.
I can't wait to start menopause and start using vaginal estrogen. I'm looking forward to it.
Okay, I think that's a few years down the road.
Really?
I want to plug your brain back, May. About this question. I think it's more about the brain. I think, you know, if you're in love and you're about to start on this journey with this partner, what a good way to start, but to talk about what you think your sex life is going to be like. And, you know, talk about the body that you are sensing and the changes that you're sensing in your body, and say, hey, you know, I haven't done that for a bit. I'm hoping it's going to be like biking, but I'm not sure. And, you know, I've kind of listened to those cool doctors, and maybe we should try this, but I don't know if it's going to work. So let's try it and see what happened. And maybe we'll need to stop and regroup and try something else. But this is what I'm going through right now.
Absolutely. Open communication. It's so hard to talk to your partner about sex sometimes, but it's the absolute key. It's a world of difference when your partner says, oh, so you've just been grinning. What is the expression? Grinning and bearing it, or white knuckling it. And that is not what your partner wants for you. But if they don't know, they don't know.
And is the person who had not had sex for many years? I didn't quite catch the whole context.
Yeah.
Okay.
Yeah, I think so.
Would this person be open to trying self-stimulation first?
Oh yeah, that's a great idea, right?
And then you can control, right? So I think if if you're hesitating or you're anticipating is sorry, the word I meant to say, this thing's gonna be painful or it could be painful, you're gonna be tense and then maybe it could be painful. But if you have had a chance to try some self-stimulation with fingers, vibrators, sex toys, whatever might bring you pleasure, that may allow your body to say, hey, I can be touched in this area. I feel safe. This is okay. And when you feel ready to bring a partner, then you're in control of that situation versus feeling the expectation to jump right into penetrative sex. I don't think that it has to be that way. I think you can have some control of the situation and maybe try some self-stimulation first.
And then you're able to give your partner some tips too.
Exactly. Then you'll know what feels good where. Yeah, exactly.
Fantastic. And I'll mention the name of that business that you mentioned before, Dr. Poirier, the traveling tickle trunk, was it?
Yes, you did good. It's on White Avenue.
So they don't travel too far. Okay, a couple more burning questions, and someone did make the joke about that being a fantastic pun. One of the questions, a couple of the questions that came in have been around constipation and or rectocele, and just being that they're, you know, in the same area. Thought maybe we could give some insight to that. So one of the questions around constipation was if like sharp pain, and I heard you when you mentioned like is it lower like on entry or is it higher up, and but sharp pain during sex, could that be worsened by like prolonged constipation? Another question that came in was about pain after sex, like not experiencing pain during intercourse, but then having maybe referral pain or pain in other areas like the hips or other parts of the body. So I'll just lob that to you all and you can enlighten us.
So I'm going to share a clinical experience. I've had a few patients in my practice that has significant pain with defecation. I guess it's not specific to pain with intercourse, so maybe it's not related, but that was related to perineal body tension. And that got better with physio and injection. So I guess I'm making a leap. I think, you know, if you have constipation, you're more at risk of having those tense muscle. If you've had pain with defecation, you know, your muscle are likely to have reacted.
Totally.
And if you have a tight perineum or a tight muscle around the vulva in reaction to the constipation and the pain with defecation, you could definitely have increased pain with intercourse.
Another thing can be, I don't know, when we examine vaginas, like with one finger inside the vagina, some patients I'm just like, whoa, there's a lot of poop in your rectum. So if I would imagine if you're having sex and that
is full of hard
poop, and then the rectum will spasm against the intercourse, I could see that being like quite painful. So our answer is always constipation has to be, everything's possible. And yet really trying to address the constipation could probably help with that.
Do we have good ways to address constipation?
Oh yeah.
Lana?
Oh yeah. So constipation means different things for different people. You can poop every day and still be constipated. If you're having to strain or to push and put pressure to get the poop out, if it comes out in little rabbit poop looking things, those can be signs of constipation. Pain, tearing sensation with having a bowel movement, bleeding, all not normal. Some preventative things you can do is drink lots of water. Your bowel needs water to, you know, hydrate essentially the poop and get it to move along your bowels. Having lots of fiber in your diet can help, but you have to have the water with the fiber, else it's going to have the opposite effect. A super safe product anybody can use is what we call a PEG-based laxative, PEG, and some brands would include Laxaday or Restore Lax. They come in a bottle. It's like a white little crystalline powder that you measure out in the cap becomes the measuring cup. Put it into a clear liquid, dissolve it and drink it once or twice a day. And you want to do this every day until your poops are the consistency of toothpaste. Okay. And then that means that they're soft, they're easy to pass, they're not painful. Other things you can try are gentle stimulant laxatives like Sanaee. You may have seen on the shelves at the drugstore. I don't recommend routinely using milk of magnesia, but some patients do find relief with magnesium supplements or magnesium powders and that kind of thing. generally safe. Maybe check with your healthcare provider first. I don't recommend routine use of Docusate. Don't know about you guys. It doesn't tend to work. It just squeezes your bowel. And if you're super impacted and constipated, just squeezing on the muscle of your bowel is going to be really painful. So again, hydration, some fiber or fiber supplement like Metamucil or what's that brand cereal? It's in my cupboard. With the pellets.
All brand?
Brandbuds, that's the one. Thank you. Those are all good preventative measures. Or those PEG-based laxatives, Laxative, Storalax. Use them once or twice a day. Clear yourself out, and then we get soft toothpaste-like stools that are easy to pass. Chances are everything has gone back to normal.
And when we think about other reasons, because part of the question was people who might have pain after sex, but not necessarily during, just looping back to the first comment about muscles, to me, that's a Charlie horse. That's a muscle pain. That's your pelvic floor is exhausted now because it's being trying to protect itself. It's being in tight mode. Now the sex is over. It tries to release, but then that's when the spasms begin. So again, the answer is physio. I think how many times have we said that? And physio helps with constipation too.
Yes.
Because there's proper way to sit. There's positioning, knees above hips. There's colonic massage. Yeah, physio.
Absolutely.
Unicorns, so magical.
There was a question about Dr. Mary Claire's new book, The New Menopause, and I accidentally pressed that we would answer it live. I was just wanted to say, yes, great book, please read. So that's my answer to that one. So
Menopause Manifesto too. Have to make a plug for Dr. Jen Gunther.
Absolutely. She's one of us.
She is, and she's Canadian. She's from Winnipeg.
And I was also going to ask Dr. Sanaee, when you were speaking, there were two books side by each. One was the workbook, and one was and one had a foreword by Emily Nagoski that I've read her Come Together book, and I thought that was a really great like psychosocial explanation. But yes, Come As You Are. What were the two books that you listed there? Because I just didn't catch their names.
Sure, it's the main book is called Better Sex with Mindfulness, and it's by Dr. Lori Brotto, Brotto. She's a psychologist, sex psychologist out of Vancouver, and then she created the compendium, which is a workbook. And in our clinic, we offer the 8-week intensive mindfulness course for pain with sex, but you can do it on your own with this workbook because the program is what she wrote. So you are more than welcome to do it on your own. The group setting is nice because you do have a group of women who are going through the same experience, so you get that support group piece of it, but it is a great resource, so highly recommend it.
May, can you talk about the evidence supporting mindfulness? Because I find that it's as a bit of an alternative technique or therapy. I think it's sometimes either dismissed or not taken seriously.
Okay.
But we know it's great.
Yes. So somebody even mentioned meditation in the questions. Mindfulness was brought to North American medicine mostly originally for chronic back pain in the 1980s, but then study after study that looked at it for other pains kept finding excellent results. So as a surgeon, for me to, I would say, do this mindfulness course, I hope means something to patients that it is more powerful than my scalpel can be in many, many circumstances, especially for pain with sex. It's a course where we learn how to meditate because we're actually trying to rewire the brain. Because we have that power, we can retrain how the brain processes any information, what we hear, what we smell, what we feel, including the stimulation during sex. So that is highly evidence-based. There's actually randomized control trials for pain with sex being treated with mindfulness, and we don't have that high quality evidence for a lot of things we treat just because it's so hard to organize high quality studies. So we definitely recommend it, and it doesn't mean you have to be part of a course to do that. You can read the book, find pelvic meditations. There's so many apps and so many resources available these days that it's really amazing what we can do.
And often those resources are free.
Yes.
In a world where a lot of things are expensive.
Yeah.
And there's an aspect of being persistent too with mindfulness. The longer you practice, the more often you practice, the more results you get.
Absolutely. Like, it's so amazing. Every time we'll have a couple of participants in our group who will, oh yeah, I didn't do the homework. And then when I see them in follow-up, oh, their pain's not better. And then the ones who diligently did it, they get the results, 80% improvement, almost 100% improvement. But we don't usually see that peak until 1 year. So it does take time to rewire your brain, but it can be done.
And I'm just going to share my screen for a second. So I actually keep a little reading list that I give to patients. And I have all of those books there that we were talking about, or at least 3 of them, Come As You Are, Better Sex Through Mindfulness, and the Menopause Manifesto. These are all available in paper, like good old-fashioned paper book, audiobook, and ebook, and the library has them all for free. So very accessible for patients. Those are the ones we're referring to. And I will stop sharing my screen now.
Thank you for that. That's fantastic. And I do want to be mindful of your time and of course your expertise. Thank you so much for all this information and for answering so many questions. I know I think Dr. Kelly, you're still typing away on some of the questions in the chat. So thank you. Yeah, no, don't worry. I'm going to just share my screen now, which has a QR code where you participants can find a survey that you can fill out, and you can also become a monthly supporter for our Women's Society. Again, I just want to thank all of you so much for being here and for all of your knowledge and insight and for facilitating such a fantastic discussion, because we love the information, but also continuing with the conversation in the questions and answers, but also the way you designed your presentation to answer some of those questions that were collected. And please know, participants that are here, we do read all of your questions, and we do access the Q&A even after this session ends. We have access to those questions, and so we do our best to continue to provide content that is going to be able to answer your questions about these intimate topics. The QR code on this slide links you to our donation page where you can become a monthly supporter, and we do support clinics like the Chronic Pelvic Pain Clinic and all of the Lois Hole Hospital for women. So if that's meaningful for you, we would be so grateful for donations from any participants that are present. A huge thank you to Alberta Blue Cross for being our sponsor for these events. We could not do this without them. And again, you will receive a feedback survey, and we read all of those surveys, and we do our best to bring that content to you every year. So please fill out the feedback survey, and you will be entered to win a gift card courtesy of Alberta Blue Cross. So when you get an email from Alberta Blue Cross that says you're a winner, you really are a winner. It's not a scam. So do fill out those surveys, and you could be entered to win. Our next Between Us is actually happening next week. So we do these monthly, but the way this fell, we're May 30th today, and then next week we're going to be at the Royal Glenora Club in person. So you will get some more information about that in your inbox following the presentation this evening. This presentation has been recorded and will be uploaded to our YouTube channel shortly. In the next few days. You can find it there. So if you want to pass this information on to anybody that you think could use it, or you missed the name of someone to follow on Instagram, or the book you want to read, that will be on YouTube shortly as well. So Pelvic Pain Docs collectively, thank you so much for being here with us tonight. We're very grateful for all of you and your expertise and the work that you do at the Lois Hole Hospital for Women. So have a great evening, and thank you so much.
Thank you for having us. Good night.
Good night.